80 people, which is fantastic. So please be reminded to turn your microphones off if you're not speaking. You can turn your videos off too, and you can keep them off if you'd prefer to. It's a 2-hour session, so I'm sure that you may find that you need a break in between. So do please feel free to move around and rejoin us when you come back. If you've got questions as we go along, please type them into the chat box during the presentations if you can, and we'll try and answer as many of those as possible during the question and answer session that we will run towards the end of today's event. So on to the event itself. We have some excellent speakers joining us today. We're going to first hear from Lorna Hales and Emily Richardson, who are both learning disabilities liaison nurses here at UHBW. They'll talk about health inequalities and why these matter, and we'll look at how our hospitals support patients and their families. We'll then hear from some of our partners in the health and care system. Tracy Bartholomew joins us, who's the Community Learning Disabilities Nurse from Serona Care and Health. And we'll talk about the links between care provided in hospital and care provided in the community. And Julie Gowanlock from Carers Support Centre will talk about the work that they do to support carers of people with learning disabilities. And finally, we'll hear a story from a family about their personal experience. And then at the end, I will chair a question and answer session so that you can ask all of those questions that you've noted down during the whole session. So before we hand over to Lorna and Emily, we're going to play a short video which we made last week by our trust to mark Learning Disabilities Awareness Week. And we hope you enjoy it and enjoy the event. Learning Disabilities Awareness Week will take place from the 14th to the 20th of June with a focus on arts and creativity. This is a great opportunity for the family of patients and staff to share activities and resources. Last year, this Awareness Week was focused on health. And being a health provider, we know that making adjustments in the care we can provide can make such a difference for people with learning disabilities, not only for our patients, but for their families and carers. So although this year we're looking to get creative, it is as important as ever that we do not lose sight of the difference we can make as healthcare providers. In the light of this, we will be holding a Health Matters event about the Trust Learning Disabilities Liaison provision on the 22nd of June.
Learning Disability Awareness Week is one of my favourite times of the year in terms of work-related activities. It is time to reflect on some of the challenges for people with learning disabilities and their families which they have faced during this difficult time, and recognise some of the celebrations despite this. As a learning disability nurse, raising awareness of this week has been very exciting and encouraging to hear a few clinical areas and how they are raising awareness by making use of ward handovers, our trust newsbeat and posters.
We recognise that boredom and inactivity have a negative impact on the health and well-being of people in hospital. People with learning disabilities very often don't have access to time-occupying gadgets such as iPads or iPhones, or they may need your help to use them. We have activity boxes from our colleagues in the dementia department, and we also have things such as boredom buster newspapers, colouring books and pens, even origami activities. And don't forget, our hospital passports have a green section, and on there it'll tell you the things that people like to do or don't like to do, and it may give you ideas for activities. So get out there and have fun.
By making reasonable adjustments for people with learning disabilities, we can contribute to better patient, family and carers experience and care outcomes. On behalf of the Trust and staff, we're proud to celebrate Learning Disabilities Awareness Week with you, raising awareness of the needs of people with learning disabilities when they access acute care.
I just want to say a big thank you to Jane. It's Lorna here speaking. I just want to say a really big thank you to Jane for opening up our event for us. And every time I watch that video, it always puts a really big smile on my face. It really does, because it's a real testimony and celebration for the people that we actually serve within our trust. So going on to the learning disability section, I just want to say that, yeah, this is a really, really important time. And just moving on to the next slide, I'm just going to talk about the aims of the session for today and just outlining some of the bits that Jane had already said. It's about reasonable adjustments. It's about how we deliver a fantastic, continue to deliver a fantastic service for our people with learning disabilities. So we want to raise awareness in health inequalities. In this section, I always think it's really, really important that we have to almost sometimes go back in order to remember our learning going forward and what just continues to push and drive us forward. Going to talk about a little bit about the role of the learning disability nurse and the importance of which Jane already mentioned, about how we not just focus on the individual, it's about their carers and their support and their networks and the people surrounding them. Also, we are very niche little team, very small team, but I always look to our champions, which we have in the organisation, and community partnership working. And a little bit about, I think it's always important to touch on the legislation, understand the responsibilities that we have and the frameworks that we use within our organisation around the Mental Capacity Act and decision-making processes, along with the Equality Acts, which actually paves the way for reasonable adjustments for us. And last but not least, it's all about communication. And in the video, Hayley's not actually with us today, but in the video, it does talk about communication, which Hayley described the hospital passport. So we will discuss that a bit further. So if we go on to the next slide, that'd be really helpful. And this is about the inequalities that people with learning disabilities have faced over the years and some of the evidence-based research that has gone in line with this. And this document is the Death by Indifference document, which was published by MenCap. And this document highlights 6 individuals which prematurely lost their lives from an acute trust. Death by Indifference is a campaign which was led by the Confidential Inquiry in 2013. And I must say, I was very, very proud and privileged to be one of the research nurses within that 3-year research findings, which came up with 18 recommendations, which I must say that are embedded very strongly within our organisation. We know from this research that people with learning disabilities die on average 16 years younger than the general population and are over 4 times more likely to die prematurely from cause of death, which could have been avoided. So if you move to the next slide, one of the things that that we do know from any sort of more research that we've seen and more evidence-based practice or more social care providers or any kind of learning, that we do know that people with learning disabilities often have additional healthcare needs such as epilepsy. So people with learning disabilities are 40% more likely to have epilepsy and also suffer from respiratory difficulties, heart conditions, and also constipation. So if you move to our next slide for us, please. This is the health inequalities continued, and I'm going to ask my colleague Emily Richardson to go through these 6 individuals' lives so we can remember. Thank you, Emily.
Morning, everyone. Hi there. We just thought it's really important to just share with everyone the Death by Indifference document and just have a little bit of insight into the 6 lives that kind of provide a basis for how we move forward as a service. So the first chap I'd like to introduce you to is Martin Ryan. Martin was known as a really smiley gentleman. He loved going out, loved music, loved the movement of a coach, and Martin was admitted to hospital following a stroke. He went without food for 26 days whilst he was in hospital, and this wasn't realised. And when it was realised, he was really unfortunately too weak to be helped. So the next person I'd like to introduce you to is Emma Kemp. She was 26 when she was diagnosed with cancer. She was given a 50-50 chance of survival, but really sadly, doctors decided not to treat her because they believed she wouldn't cooperate with the treatment. Emma sadly died of cancer in July 2004. The next picture, this is Warren Cox. He was 30 and he was known as a really happy, contented young man with a really great sense of humour. Warren sadly died following perforation of his appendix. His mother and father really pushed for his pain to be investigated. They queried appendicitis, they queried problems with the bowel, but unfortunately, whenever he visited the doctor, they were told Warren had a virus. The next picture, this is Ted. Ted Hughes was 61 and apparently had a really gentle nature. He loved cricket and quite often helped the groundsman at his local cricket ground cutting the grass on the tractors. Ted was admitted to hospital for a minor operation. He was discharged 3.5 weeks later, despite concerns that carers had about his health and that he wasn't actually medically fit for discharge. Unfortunately, when he was discharged, Ted collapsed and died the following day. The fifth gentleman, this is Mark Cannon. He's 30 and he apparently was a really funny gentleman and always had his family in stitches with his antics. Mark was admitted to hospital with a broken thigh. Unfortunately, died 8.5 weeks later. His family say that he was clearly distressed and in pain, screaming, banging his head, but unfortunately staff weren't aware that these were signs that he was communicating pain. Unfortunately, by the time the pain team arrived, it was too late. And the last gentleman I'd like to introduce you to of the 6 lives is Tom Wakefield. He was 20 and he was known as dear, unique and courageous. Tom enjoyed music, barbecues and football and was full of life. Tom's consultant recommended investigations by a gastroenterologist. However, this didn't happen for over a year. Tom's expressions of pain weren't listened to, and by the time he was seen and action was taken, it was too late. So I think it's just really important that we look at those and try and remember those 6 lives, 6 lives that didn't need to be lost. So I'll hand you back over to Lorna and we'll just discuss how we're using those 6 lives to move forward with our practice.
Thank you, Emily. Thank you. And absolutely. So having a disability should not be a barrier to healthcare. So in terms of our organisational response, we are engaging with LEADER, which is Learning Disability Mortality Reviews, which aims to support the improvement and the quality of healthcare, health and social care service delivery for people with learning disabilities, and therefore reduce some of the numbers of these avoidable deaths and early deaths and recognise such inequalities. We also, within the organisation, we have leader reviewers. There are a handful of leader reviewers. Please, if you're interested in being a reviewer for the organisation, I can give you the profile and detail you about that. So we're looking for nurses and people who are able to assess and recognise deaths within or report deaths within the organisation, and you're supported by the leader reviewer team. So I am a leader reviewer and Emily will soon be a leader reviewer. So we're going to have many more. So please do put a note if you're interested in our chat. We take our learning from Mars, and some of you may know what Mars is. It's not a Mars bar, it's the multi-agency reviews. Okay, and they meet quite regularly if they feel that there are significant learning that can be made for individuals that have prematurely, individuals that have died within the acute service. So we look at some of the challenges, we look at some of the failures, we look at partnership working, and this can be described within this Mars kind of network and meeting, we can look at some of them actually missed opportunities, yeah, and ensure that practice is improved and partnership working is successful and communication continues to bond us through our learning. Within the hospital, we have quarterly learning disability steering groups, and each division which within the organisation will report to this group. So it's about referrals to the team. It's about whether there were any risks or were there any learning in terms of good practice, as well as things that didn't sort of work out so well for individuals, and deal with any sort of I'm going to say positive feedback as well as complaints, because that's really, really important, because sometimes we focus a lot on negative aspects, and we sometimes dismiss as well as the positive. So it's bringing all that together. So let me have the opportunity to introduce the trust, because we've gone a bit backwards here, because we need to introduce the trust in order to introduce the Learning Disabilities team. So we are a really big organisation now since April 2020. We joined with Western General Hospital to, and there's over about, I think there's only about 13,000 staff within our organisation, and we deliver over about 100 different clinical services across our 9 sites. So our sites include the BRI, it includes Western General, Bristol Children's Hospital, Bristol Heart Institute, St Michael's Hospital, Bristol Dental and Eye Hospital. And we do have an absolutely clear vision. And it's a vision about how we're going to be a specialist service centre. It's about being a beacon and being outstanding in terms of education and research and innovation and partnership working. So that is key. So that's why we have the voice of the carer about the lived and living experience. That's why we've invited our partners here today, the Community Learning Disability team. And I'm just going to put it out there, CQC has awarded us outstanding twice. Okay, so we must be getting something right for our people that we serve. So introducing the team, so it's myself, Lorna Hales, it's Hayley Johnson, who's a complex needs sister at Western, it's Emily Richardson, who's just sat right behind me there on her own personal speaker, and we're headed up by the Deputy Head of Operational Lead for Safeguarding and Learning Disabilities, who's Deborah Parsons, and the overall anchor is Carol Sawkins, who's our Safeguarding Lead for Adult and Children. So our next slide, oh, we have got the next slide. If you go back, thank you. If you can go back one, that would be great. So our aim is to ensure that patients with learning disabilities, along with their families and carers, have a positive journey from the beginning, from pre-admission through to the emergency department, right through to discharge and right through their patient stay. So our job as a learning disability liaison nurse is to maximise this, is to absolutely maximise this. So work with the wards, work with the physicians, work with the clinicians to maximise and enrich the patient's journey. If you can go on to the next slide, please. Thank you. So the learning disability nurse, we work with, I can't even imagine, I can't tell you who, it's better if I tell you who we don't work with maybe, because we work with absolutely everyone. So from GPs to community services, we work with many hospital liaison nurses right across the trust, and we work with other community learning disability teams, social care providers and also social workers. And there's times when our individuals that come into our acute trust suffer from mental health problems and concerns and issues. So we do work with the psych liaison team and the other clinical nurse specialists within our organisations. We work with outside agencies such as the independent mental capacity advocates when people are struggling to make decisions for themselves and do not have individuals or next of kin or people that can represent them when they have to make serious decisions for their mental health, for their acute needs. We also work with service user groups. Because we're quite a small team, people think, actually, how do you do it? How do you get across the place? How do you manage, Lorna or Emily, or you know, how do you do it? It's such a big site. And it's because from the minute we get a referral for that patient and we know where the patient is on the ward, that becomes our multi-professional team. Yeah, we have our champions on the ward, we have our doctors, we have our epilepsy specialist nurses, we have our OTs, we physio, and then we become one team to make sure that we deliver a really good service for that individual. So we may be a very small, little niche, look like we're very niche, but we're very multifaceted, and we do work right across. In terms of our development, so we talked about the champions, we talked about the provision right across UHB Bristol and the footprint. And we also, I missed out, we actually work with the patients themselves and their families and carers, because they're the most important voice of all, because like some of the the failings of 6 Lives, we learn by this, by communicating with our families and carers, and we seize the opportunity for multiple procedures whenever possible. So within our organisation, we have achieved 9 procedures under one general anaesthetic. So before I retire, I want to maximise that and have at least 10 and 15 multiple procedures under one general anaesthetic. And we mitigate threat. We do a lot of pre-planning. We do a lot of DNA avoidance, because if, you know, we can't treat a seat is one of the slogans that we use within our organisation. And we also ensure that cancellations for appointments are at a minimum. So it's about getting those reasonable adjustments in place in advance. So if I can go to the next slide, please. So this is how, if you're an audience participation and you're working from inside the hospital, this is how we refer to the learning disabilities team. It's all very electronic, which is great, and the referrals sit within the patient records. In Western, we use an electronic patient record system, and also access medical files. So we are, although we're one team, we do things slightly different, because we are still in the interim of kind of merging systems. We all know what it's like in the community when we say, oh, we wish systems would talk to each other. So we're in that place now, but we're not losing sight of that's where we're going to go in the future. So when we use the Medway service order, which is a really funny name for a referral, I must admit, but that's what it's called, it will give you the opportunity, the referrer, the opportunity to think about reasonable adjustments. So already it will urge you to kind of think about pain relief, communication, constipation, eating, drinking. If you think of Maslow's hierarchy of needs, it will talk about all of that, and it gives the acute nurse the opportunity to kind of start thinking about their patient. So when we're not around on the weekend, it's already a prompt for them to start thinking, have they got a hospital passport? Did they come in with constipation, etc.? So what we're developing as well is an external referral, because we battle sometimes with lots of emails, and we don't want to lose sight of all these emails from our community partners. So we're actually in the process of developing a referral for our community partners, so they can do a direct confidential internal referral, and this will be hopefully rolled out to families themselves and individuals themselves once we've piloted it with our professional colleagues. We've also got clinical alert systems as well, which will flag on our Medway, so it will tell us little bits, clippets and snippets about the individual. And our clinical alert system, which I think I always celebrate about a clinical alert system. So once we know we have a patient in our care, it will ping us an email to say the patient's on ward A400, and then when the patient moves from A400 to A800, for example, it will ping us another email, and it will allow us to keep on top of the patient's journey while they're in our care. And we talked about external referrals. So if I can go on to the next slide, please. One of the things that Jane highlighted, our chair highlighted, is the reasonable adjustments. And it is absolutely key that if we have reasonable adjustments for individuals with learning disabilities, then we're almost there, aren't we? We really are. The Equality Act 2010 talks about it used to talk about, before it was the 2010 Act, it used to talk about ramps and rails and hand grabs and lifts and slopes and things, but now it's a bit more tailored to embrace people with learning disabilities, and it allows us to kind of think outside the box, really, and it's not one size fits all. It's about how we move around and how we tailor our service to meet that individual. So these are some basic ones. If in the chat that you think of, or you've experienced other reasonable adjustments that you think actually this was really, really good for me, it was good for my family, or it was good for our organisation, please do add. So these are some of the ones that we use, top 4 should I say. So offering a side room. We always invite families and carers if they want to stay, so we will offer a bed, a mattress, somewhere where they can stay. We always try to offer a side room where possible, but I must always add, to manage expectations, that if we're at a kind of pushed capacity within our trust, and someone with an infection comes into our care, it will always trump. Someone who's got an infection will always trump any member of who's coming in, and they will get priority for the side room, because we have to keep everyone safe. It's important to keep everyone safe. So we provide extra support. We have the enhanced care observation provision, where I don't know, I'm quite good sometimes. So if I was to come into hospital, I think I'll be all right. I think maybe, but if I'm not, or if I need additional support, there are layers. So there's 1 to 4. So level 2, maybe you need eyes on you. Most of the time. Level 3 is definitely eyes on you, and you're not out of sight. So it used to be called 1-to-1 extra support, but now it's called enhanced observation and meaningful activity. And enhanced observation level 4 is where you have someone at arm's reach. Okay, so we try to minimize waiting times, first on the list, first appointment, etc. And we also provide easy reading materials, and we create bespoke ones, so we tailor ones, and we also invite our community partners to bring easy read materials in as well. So if we go over to the next slide, the hospital passport is absolutely key. I'm just looking, because I do talk a lot and I know this, I'm just checking the time. All right, and I'm going to give you a little story with this. So the aim of the hospital passport is to assist people with learning disabilities that come into our organisation who are unable to communicate verbally their needs during their time with us. It is a responsibility for our community partners, families and carers to complete the hospital passport, and there are absolute many. I saw Hayley in the video holding one up. There are many, but there are the main aim of them is to act as a communication tool for acute staff in the absence of families, carers and friends. So I guess it's important that we keep them updated. We have to keep them updated. They have to be fresh. They have to be a live document for this individual as they present to our trust. If we go to the next slide, the hospital passport is a like I said, it's a patient-led document. And it could be completed at home, and it can be sent in to us. We can attach it to electronic databases. We can send it to the wards in advance. We can use it as a communication tool with other professionals. So it's a great tool. I don't know if you guys can see this, but at the bottom of this particular document, it talks about the Mental Capacity Act, and it talks about, it kind of gives us a snapshot of the lasting power of attorney, whether it's for welfare or whether it's for finance. So if you're filling this out at home, if you put your details and relationship and contact details right on the front page there, we will know at a glance if a serious decision is required and needed to be made. We know that there's some LPA involved there. So if we go on to the next slide, this is where I'm going to share my story. So this red circle is the most important circle of all, I think. I'm just going to take a sip of water. but it's one of the most important bits of slides. And this is again about the reasonable adjustments. So if you think about the 6 slides, and we talked about Mark, about him being very, very distressed, him being, carers being really concerned, and there was delay in the response for pain management. So this is about the Abbey pain scale needing to be in place. This is about telling us that the patient requires certain reasonable adjustments about their care, and it can include nutrition and elimination, etc. So it's really important. So I want to share with you to give you a little bit of impact on a hospital passport and its importance. So when you go away today, you're going to go, hospital passport, must have, must have, must have. Okay, so I had a referral a year or so ago, and we've had many positive ones, but this one's very, very dear to me. And we had a referral for a patient coming in for an upper GI procedure. And it was a Medway service order referral, so it came to us way in advance. I contacted the parents and spoke to the patient's mum, and it was such a great kind of information sharing time. And we were able, and mum was able to put the hospital passport together with all the reasonable adjustments. So I then kind of jotted away and clipped it on absolutely everything, disseminated with all the receiving teams. So on the day, on the back of the hospital passport, it said, this is a gentleman, an adult male, who's around 25 years of age. And on there, it simply said, when I become distressed, I need you to play Wheels on the Bus. Okay, and I don't know if you guys know, wheels on the bus go round and round. Oh yeah, but he's 25, but that's what keeps him calm. So that's the most important thing to him and his family. So when the parent and the patient arrived to, we went really swiftly through pre-op, and all that was on the hospital passport, and we really moved really slickly all the way through. And when everything was done and we were prepped for surgery, we were on our way with the porters and with the nurse, and I was there with mum, and mum was talking to her son, and we were having a good old chit chat. But then something changed, something very subtle, which not even I picked up. And I've been a learning disability nurse for 32 years, and I'm not the expert in terms of that individual. The parent and the carer are the expert. They're the lived and living experience for their loved one. Have the living experience for their loved one. So there was a subtle change, and mum started to sing. So now, I don't know, those who know me know I love to sing. So mum takes the soprano line, I take the alto line, which isn't my favourite, but I did, and I started singing. So we sang Wheels on the Bus, and we were singing all the way, and immediately he started to calm. So I don't know if you guys know the structure of our buildings, but Haygrove Theatre, the doors kind of like open like this. And as we were entered the room, guess what was being played by good old Spotify? The Wheels on the Bus. And that's the importance of the hospital passport. So it was playing in full, but mum couldn't believe it. I couldn't actually believe it. You know, I was just so amazed and so impressed. So in order to get the best out of our best for our patients, for their patient journey, it's important that we do really push hard on the hospital passport. If we go to the next slide, the hospital passport will also talk about, will give us guidance around communication and what type of communication that individual will require during their care. And I've been in meetings and lots of kind of jargon and lots of fancy talk and stuff. I think we just need to be mindful that we have to keep it very clear, keep it very precise, and allow people time to process information. Because that's the key, because if we bombard with individuals with lots of information and jargon that they actually don't understand, because it's far too complex, and the decision that they're having to make is a very complex decision as well, and then being bombarded with communication that they don't understand. we use pictures of reference and objects of reference and pictures as well. And I've been on the wards and been in best interest meetings and capacity assessments, and I've seen surgeons drawing pictures of eyeballs and sockets, and I've seen the Heart Institution, they come out with big molds and statues of hearts, and it's learning for me as well. So we always try to use objects of references as well, and we always try to think of maximizing the time when we do capacity assessments and we're communicating with individuals. If the morning isn't a good time, then the morning isn't a good time. Let's come back in the afternoon. So it's about reasonable adjustments all the way. So if we go to our next slide, please. We use this. This is one of the things that was quite dear to us. We use the hospital communication book, and we encourage our wards to have them in their areas all the time. And we're able to create bespoke easy read material and I think I mentioned this earlier, bespoke individual easy read material for the patients within our care. And if they want Star Wars, we create Star Wars. If they want Harry Potter, if they want anything, we will create social stories and things around their care. And again, I think I did mention even recently, one of the community learning disability teams has shared with us some easy read tailored for an individual. So if we go on to the next slide. So if we do all that, we're gonna enhance our opportunities for gaining consent for people with learning disabilities. And in the past, it was commonly assumed that people with learning disabilities weren't able to, have capacity or even be considered to have capacity, but with knowledge and training, we support those who are the decision makers or end up being the decision makers within our organizations. When people lack capacity, we begin to support them and encourage them. This quote by William et al., I think it's really, really helpful, because it was found that practitioners often find it challenging to determine when an assessment or capacity should be made. And I know our adult safeguarding team work tirelessly in terms of making sure that everyone's up to date with their Mental Capacity Act training and deliver refresher training. And so does the Learning Disability team. We offer bite-sized training for Mental Capacity Act processes. And it's about how we instill confidence, because I think if a surgeon said to me, "Oh, Lorna, here's a tool, can you just go over and can you do this to I think I just fall flat on my face. There's things that I'm not able to do. So it's how we work together to bring all the skills together and work in partnership to make sure that we ensure that all voices are heard and the Capacity Act process is actually pivotal to what we do. So if we go to the other slide, some of you are going to be really, really familiar about the principles. So we must always presume an individual has capacity, and we talked about changing up the times of day when we do a capacity assessment and just making sure that people have every opportunity to make a decision for themselves. And if they can't, we have the documentation to support this, and we will hold best interest meetings. And during the COVID pandemic, it was about discussions. So we were all online, Zooming in, having discussions with our community partners, families, independent mental capacity advocates, if individuals did not have someone who could represent them, who could not be consulted with, or a best friend even to represent them. So we do have systems in place. We support our decision makers to be the best they can in implementing these processes, and we are accessible through phone, through email, through bleep even. So we can be bleeped and contacted, and we can be as responsive as we possibly can. I'm just going to share with you, in April 2022, there is going to be some amendments to the Mental Capacity Act. So I would urge you to look at .gov. I know the safeguarding team are in the process of working on this amendment, so the Act will say 2019, and that will be around deprivation and liberty safeguards, and it's going to be about shifting the responsibility, taking it from the community and social care local authority to acute trusts. So that's going to be coming up. So we're going to have training. We're going to have, we're going to be supported in getting to grips with the new bits of legislation. So there we go. So I'm just going to go on to the next slide, if I may. So when we make best interest decisions, it's just absolutely key that we have the relevant parties around the table, and we make sure that in advance we know if there's lasting power of attorney, if there are patients' wishes, because I was in a meeting the other day and it just rained in and rained true and resonated with me that the patients' wishes are absolutely key. They may not, because some of us may not be able to understand the percentage of the drug of the anesthetics and all of that complexities, but when it comes to fundamental what you actually want for yourself, that can be that can be put in writing. It can be past wishes in terms of what you've communicated with your carer and loved one, and you share with us, and that must be taken into consideration. So coming to almost to the end, just a few more minutes left before I hand over. So some of you may have experienced the role of the learning disability nurse and come in contact with us. We are very multifaceted, and a lot goes on behind the scenes in terms of how we develop the service and continue to turn the wheel around, and we just want excellence all the time. That's what we want all the time, and sometimes it's not so near to us, but that's what we want to achieve always. That the end game is we want to provide an excellent service. So the plans for the future, and some of them are kind of almost imminent and in the pipeline. So we're developing a feedback form. So we've had various types of feedback initiatives within the organisation, but we've got this really good form that we're wanting to develop. We have learning disability champions, and we're going to refresh the learning disability champions role, and we're going to publish it soon, a drafted kind of template of the learning disability role. So if any of the other acute trusts wanted to share, wanted us to share this once it's published, please leave us a note in the chat, and we're happy to share this. Hayley talked in the video about activity boxes. We have been relying and tapping into the dementia box, but we have actually applied for our own activity box, which will be filled of sensory activities for our patient. And we're looking at developing the external referrals, which we talked about, and we continue to develop meaningful links with our community team and social care providers. And also we're updating our website and resources. So I've looked in the chat. It's really hard. I find it very difficult to, I say I can multitask, I'm multifaceted. So I'm hoping that some of the slides have answered some of the questions. I know children's have come up into this, and we are a part of the transition steering group is represented by our head of nursing. So and we work very closely with our partners within the children's team, and also Jessie May. We've worked with Jessie May, and also some of the hospice in terms of referrals to our team. So we do work within transition and very mindful of the transition policies that are in place. So I've got a note to self to say stop at 10:45, and it's just gone over. So I would like to just go on to the next few slides, because there are some resources there. Please do take a screenshot if you want to of these resources. And if there's any resources that you have found that that we can share, then please do that. And then we've got the next slide, which is our contact details. All right, so I'm going to introduce Tracy Bartholomew, who is the Community Learning Disability Nurse working for North Somerset CLDT, if that's okay. So thank you. Thank you for your time.
Thank you, Lorna. Good morning, everybody. Much of what I would usually say when raising awareness of improving support and health of people with learning disabilities has already been covered by Lorna and Emily, so thank you. But one of the key things I think that is worth definitely reiterating again is that we as learning disability nurses are always learning from the people that we support and everybody else around. And it's really important to be learning together and moving forward together. My part in today is to be speaking to you about the role of our community service and I want to share an example with you about how I found working together can greatly improve the experience of a person with a learning disability. Okay, so I work in one of the 3 community learning disability teams that make up Sirona Adult Health Service. Just to give a little bit of background, similarly to Lorna's service, last year in April 2020, we merged from being 3 separate community health services, so Bristol Community Health in Bristol, North Somerset Community Partnership in North Somerset and Sirona in South Gloucester, to be becoming a BNSSG, so Bristol, North Somerset and South Gloucester wide Sirona. The transformation of these learning disability services, we're currently going through transformation because obviously with coronavirus there was a lot of focus on supporting people to manage and understand that situation and to support them through that. We're now looking at the moment at what works well and learning from what works well from all of the areas to shape our wider service moving forward. Next slide, please. So this is just an idea of the types of people that work in a learning disability, specialist learning disability community service. So we do have nurses, we also have psychiatrists, psychologists and behaviour specialists, and we have allied health professionals, so physiotherapists, speech and language therapists, occupational therapists, and we also have access to dietitians, specialist dietitians and creative therapies, which is art, music and drama. And that's really helpful to support people who are unable to express their emotions verbally or in the usual ways. They can express them creatively. Next slide, please. So just to give a little bit of background on how we work as a service, we work on a referral basis with episodes of care. So there is sometimes people assume that because somebody has a learning disability, they are known to us and we work with them, sort of on an ongoing basis. That's not the case, but more often than not, we are aware of somebody, so are also, definitely worth linking in with. We could work directly with adults who have a learning disability, but we also support family members and care teams to enable those people to have a better health and support system. Making reasonable adjustments, as Lorna has spoken about reasonable adjustments, very, very important to for these to be made to support people, and they're the responsibility of everybody, but we can advise and support other people on how to make reasonable adjustments if they're struggling. So, and with regards to the specific areas, key areas, as Lorna was saying, that people with a learning disability suffer more with. So we have epilepsy reviews, dysphagia, dementia. We have reviews for people that have behaviours that may challenge, so positive behaviour support and postural management. And these are always worth sort of checking in with us from the hospital perspective if you want to know a little bit more about that person, how they are on a day-to-day basis. We also develop pain profiles and bowel management plans. Next slide, please. So I just wanted to talk you through, it's actually quite a recent case study, but hopefully it reflects on how useful it has been for us to link in, develop those and build upon those relationships within the hospital and external to the hospital. So we have an agreement with local hospitals that they advise us when people from our area are admitted to hospital. Now, recently that happened, and a person was brought to our attention, and on the notification it said known to the learning disabilities team. Now, I checked our system and noticed that although he had been known to us, this person hadn't actually had any input from us since 2017. Sorry, yeah, 2017. And on checking with social care colleagues, they said that yes, we are aware of this person, but they have no package of care, therefore we're not currently working with them. So that kind of left me with a little bit of a quandary of, this person is assumed to be known to us, but actually, if we hadn't had that notification, we wouldn't have known the situation that person was in. So a welfare call was made to the family, and they were managing quite well, pretty well. But that person did require ongoing treatment in the form of dialysis. And on speaking with the family, it became apparent that there were other caring pressures. That person's sister was actually supporting both parents as well. So it became, evident that it was quite a vulnerable situation. So, and all they wanted was just some support with that person's ongoing dialysis. So we spoke about that, and I said, I'll go away and see what we can do. Next slide, please. So I linked in with the hospital, and because it was outpatient treatment, it was identified that the community services and social services needed to be looking at the funding. So that was fine. It was good to have that clarity because it wasn't something I was overly familiar with. So I then went to other, discussed it with CCG, and a referral was submitted, and actually the funding was agreed within 24 hours. And the brokerage are currently liaising with the family to provide, to find a suitable provider. I suppose I just wanted to share this because I found that, the positive outcomes for me were that person's current situation with their health has now been raised with community health and social care services. The funding has been sourced, and that the relief in the voice of the person that I spoke to on the phone was unbelievable. She felt that small amount of help was going to make such a massive difference to her and her whole family. And it's also triggered a referral to our service, and we can then identify current needs and onward referrals thereafter. So hopefully it's kind of completed a bit of a circle. And obviously I just wanted to put that the risk of not sharing would be, ongoing stress on relationships between that person and their family, and potential carer burnout, which obviously we do not want to get to. Next slide, thank you. So with working together, as again Lorna was saying earlier, it's about building on those relationships, and we have been strengthening the process for information sharing. And that there is a system to inform community teams where a person with a learning disability is admitted to hospital. And we also do, vice versa, if we're aware of someone that may be needing to go into hospital, we do endeavour to make those links as well. When the person's in hospital, sharing of information can be really important from the community. Specific care plans, eating and drinking guidelines, epilepsy management plans, even the awareness of someone's pre-admission mobility status can be really helpful to sort of guide those that are caring for that individual whilst they're in hospital. And hospital and community teams being involved together in discharge planning could really ensure, that the correct support and equipment is in place if that person's needs have changed, and it can prevent delayed or failed discharge. Next slide. Hospital passports, obviously, Lorna has spoken quite a lot about hospital passports, quite rightly, and as she said, there's a big part that community teams play with that. We've always promoted and supported the use of hospital passports, and the key uptake of these was a key focus of our COVID-19 work. If we were made aware of concerns regarding the accuracy or quality of these from the hospital or others, we can then link in with the person and their support team to support the improvement of that. So definitely see, you know, sort of us working together with regards to that area. We too have learning disability champions being identified. For us, it's within our within our GP practices, and we've started to link in to provide training and ongoing advice and support, especially in the areas of reasonable adjustments, annual health checks, and the use of Mental Capacity Act. And we have an advice line for each of the 3 teams in the Learning Disability Service, which is shown on the next slide. Next slide. So, and the aim of the advice line is to encourage open lines of communication and provide clarity on what support is available. It gives their general advice on somebody with a learning disability that we may or may not be aware of. Specific case discussion can be had. Information on our current referral criteria, and just to note that referrals for all of our team can be made by anybody, an individual with learning disabilities, their carers or other professionals. Other than that, for our psychiatry, they do require a referral from a GP or other medical professional. And next slide, please, is our final slide, which, sorry, you'd already gone to the next slide, I think. So the last slide, that's the one, is just the details of the advice line contact. So thank you for listening to me. I'm now going to hand over to Judy.
Hello, much for inviting me to talk. My name's Judy Lock. I'm employed by the Carer Support Centre, which is a small charity that supports unpaid carers looking after somebody who lives in Bristol or South Gloss. And I work within the hospitals as part of the Carers Liaison team. So I'm going to talk a little bit about some issues for carers in hospital, and some of the things I'm going to mention I think have already been touched on previously. And I'm going to talk a bit about things that I think are important for carers to know pre coming into hospital, what we can offer as a team, and our contact details. So if I could have the next slide, please. Thank you. So I thought, thinking about this, what might be some of the issues? I've got on my next slide, I've listed some issues, but one of the things that I think comes up for us is sometimes about transitions. And what I should say is, at the moment, we're working mainly, we're a small team as well. There are 4 of us and we're all part-time. We're working mainly in the BRI, the Eye Hospital, the Heart Institute, the Oncology Hospital. We're trying to develop a bit more in the Children's Hospital. And the reason that I sort of mention that is that I think one of the issues for carers of somebody with a learning disability is sometimes around the transition. And I think sometimes it's just around sort of terminology. And I was thinking about this. So when you're looking after a child with learning disabilities, you're often referred to as a parent carer. And then when you move into adult services, you're an adult carer, but you're still a parent to that child. So I just thought that was something that was interesting to me and that stood out. Could I have the next slide, please? So I've worked in the team for about 6 years, and I could say to you what I think carers say to us about what makes a good hospital experience. But this slide comes from Mobilise Online, which is a charity that it's sort of really developed during lockdown, and it's an online charity for carers, and they've got some really good stuff on their website. They do lots of online social events for carers as well, online cups of tea. And they came up with this, and a lot of this I think relates to reasonable adjustment. So where carers were saying they like it when hospitals understand their care for needs. So that's things like knowing what a hospital passport is, I think making reasonable adjustments, minimising waiting time, having a separate room available, allowing carers to stay with a patient to ensure that their needs are being met. Trust that involves us in the care plan. what carers say to us is they want to be treated as expert partners in the care of the person. And that always sticks out for me. One carer I supported quite a few years ago said to me, you know what, Judy, I just want to be treated as an expert. I've got knowledge. I want to work with the team. The carers want to be listened to. They want to know that they've got useful information that they can share with healthcare professionals. Carers also want to have receive proactive and practical advice. And again, I think that's been talked about in some of the earlier discussions. Lorna talked about diagrams. It always sticks in my mind a carer saying to me, she felt really stressed and overwhelmed, but when a nursing staff showed her a diagram on her phone of the part of the brain that had been affected, that just brought it all to light for her and she understood. I think also having flexible appointment times and whether those are by phone or face-to-face. Again, this has been talked about in terms of reasonable adjustment, but understanding that waiting can be very stressful for a lot of carers and the person they look after. Having a clear discharge policy so that carers are involved in the discharge process. So they, when somebody's discharged, all the relevant information has been passed on to the carer. Understanding the impact of the carer. I think we've touched a bit about carer breakdown, but also just understanding sometimes the stress that caring has on carers. It's also understanding things that like might be a 5 or a 10-minute appointment for a carer behind the scenes. That might have been several hours of travelling and planning time. And also hospital staff being contactable, so answering phones. Those are things that carers have said are really important. Could I have the next slide, please? So before admission, I'm not going to say anything more about hospital passports or the learning disabilities team, but two things I just draw out from this slide are we've drawn up an admission checklist, which is downloadable from our website. We can also send a copy to carers if that's helpful. And also contacting our team, we can give you some advice, and I'll have our contact details on the last slide. If I could have the next slide, please. The other thing that I think it's really important for carers to be aware of is the Carers Charter. So this is an important document. It was updated in November last year, and it's been signed by both trusts. And it's about providing a culture of supporting and working in partnership with carers whilst in hospital. And it has 6 parts to it. It's treating carers as equal partners, supporting carers, recognising young carers, sharing information, giving carers a voice, and also involving carers in discharge planning. And my feeling about the Charter is that it's really important for carers to know about the Charter, but equally it's important for staff to know about the Charter, because then we can make the Charter a really valuable document, a document that means something. And certainly in terms of my role in training and development within the hospital, I've been focusing on promoting the Charter and making sure that staff know about the Charter. Have the next slide, please. So what do we do as a team and how can you contact us? So anybody can refer to us. We've got our email address, and on the next slide I'll have our phone numbers. So if you're a carer and you know a hospital admission is about to happen, you can contact us by email or you can phone us. You can ask hospital staff to refer to us, and they use the same email address to refer to us. Or you can contact the Carer Support Centre at Carers Line, and they can refer you on to us. I would say, probably similarly as other people have mentioned, it is about working in partnership with the hospital to raise awareness of carers' issues and make sure that the carer is taken the carers' views and the carers' knowledge is taken into account. So a lot of what we do for carers is around providing emotional support. We're not counsellors, but we can listen and we can empathise. And that's the thing that I'm most proud of our team, is that's the thing that we get the most feedback on. And that's what I think is the most value that we provide to carers. But we can also explain hospital processes, we can do a bit of liaison, we can communicate needs or concerns towards staff. We can attend meetings with carers. So at the moment, we're working remotely, but we do hope to come back into the hospital in the next couple of months. And we have been attending meetings online, but we can attend them in person. We can ensure carers are involved in the care of the person they care for whilst they're in hospital. Or equally, we can support carers to use the time to have a break from caring. And the other thing that we do is we take a fairly holistic view. We can speak to carers' benefits, carers' assessments, and we can signpost to other services. So if I could have the next slide, please. I'm not going to take questions now because I know we're going to take them a bit later on. But this is our email address again, and my wonderful colleagues who work directly with carers. So Tracy works mainly in the BRI, and the Central Bristol Hospitals. Judy Porter has just joined us this week. She's working with Tracy and also with Sam, and Sam mainly works at Southmead Hospital. So thank you very much.
Thank you so much, Judy. That has been absolutely amazing. Thank you so much, and such knowledge. And you know, I've put in the chat a couple of things that I think, oh yes, we need to be on it. We need to be on it. So we'll because I'm liking the idea of this link bit as well, and this pre-admission kind of checklist. I think we'd find that really useful. So thank you so much. So moving on, if we can, I'd like to introduce our Mrs. Withy, who will share with us a lived and her living experience.
Hi, good morning everybody. Thanks for asking me to come along this morning. I'd just like to say I'm a little bit nervous because it's the first time I've done anything like this, so you'll have to just bear with me and excuse me, but hopefully I'll try and sort of get over some useful information for you. So my name is Sharon, and I've got a 20-year-old son who's profoundly physically disabled. He stopped breathing at home when he was 4 days old. And after many months in and out of the children's hospital, he was diagnosed at about 5 months old with cerebral palsy. At about a year old, we learned that he had quite a rare form of cerebral palsy called athetoid cerebral palsy, which kind of translates now to he's got a complex movement disorder. He's also, over the years, we've learned he's got quite significant learning disabilities. We were advised, though, from a very young age by an amazing health professional that young people with athetoid cerebral palsy often have a very high level of cognitive ability. So we were given advice to treat him like any other young child and, you know, don't have any less expectations on him, which was probably the best thing we were ever told, because that's what we did. And I think that's why he's sort of developed into the brilliant young person he is today. We've also got a 17-year-old daughter, and we basically all live at home with my husband as well together, although my son is potentially starting a part-time residential course at college soon. So things are moving on and changing for him. He's an outgoing, sociable young man who loves spending times with other people of his own age. He's got a really great sense of humour. He absolutely loves music, although he's got quite an eccentric taste in music. He's a super fan of the Wurzels and has attended many live events over the years. I don't think his carers always appreciate that taste in music, but we've got used to it. He's very brave and he's very strong, and he's got a very, very strong character, despite all that the limitations of his disabilities places on him. If he's spending time what he wants and the things he enjoys, he can be very happy. But alternative to that, if he's not doing things that he likes and he's not getting the stimulation and all the things that make his world tick, then he can be very unhappy. can be really challenging with his behaviour. Unfortunately, because he is very bright, he suffers with a very, very high level of anxiety, which he can display again in challenging behaviour, both physically and with noise, which can have an impact on him and others and his carers. And he really, really requires routine and consistency in his day-to-day living. He's reliant on 2 adult carers for all his cares 24/7, which is often myself, often my husband, and we have I say a team. At points we have a team of carers, but that can be challenging in itself to meet his care needs. He's got many health problems and he needs to come into hospital probably on average 6 or 7 times a year. Some of those are acute stays and some of those are planned stays. He recently needed a dental procedure at the BRI, and this was our first ever visit to this hospital, because where we live, we normally come under Southmead, so that's where most of our experiences have been. I was really, really anxious about him going to a completely new environment where nobody knew him, and I was just worried about sort of all the things that needed to be put in place to enable that visit to go smoothly. So I was put in contact with the learning disability team at the BRI, and straight away they gave me positive reassurance that they were going to help and support me with the stay. I spoke to several members of their team. They took lots of information down about my son, what we would need to make our stay easier and better to manage, all the types of equipment that we were going to need. They asked for his hospital passport that had already been set up at Southmead to transfer over to them so they could pass this on to the ward staff. And they also had other ideas as well about things that could be put in place, like they arranged for him to have bloods done during his procedure, which have to routinely be done every 6 months, which can be challenging. And they just asked a lot of questions, that open questions, like other things that could be done to make the stay easier other than the obvious, which was really, really helpful. They arranged for me and my husband to come in as both his carers to support him during the stay, which is absolutely crucial. There's no way my son could come into the hospital and be left and be looked after by complete strangers, even with a care plan, even with a hospital passport. He's non-verbal, and it would make his stay almost impossible, and it would also be just too much for the nursing staff to manage. So just having that, just having the knowledge that and just the reassurance that we could go in with him for the whole duration of his stay, in the midst of COVID as well, which has brought along a lot more stress and anxiety because of the limitations on people being in hospital. But it was just a really, really positive stay. We had a separate room, which is really important to him. There was a hoist already in place when we got there, which is again really important to him. The staff knew about us when we came in. They were expecting us. They had knowledge of his disability, which again makes just life a lot easier. There's not sort of surprises when we turn up. And they think, oh dear, like, how are we going to manage this today? You know, because he is lively and he's a young adult now. He's big. But everything was in place. The nursing staff were just fantastic with us, really supportive. They arranged for him to have a separate area on his own in the recovery area, even though the facilities at the BRI are challenging for people like my son. You know, there isn't necessarily the space that you get at other hospitals, but they made it work, you know, with the space that they had. They speeded up our discharge. They already went ahead and organised his meds. So the minute he was well enough to leave, we could leave. We didn't have a lengthy stay after, which again, it just adds more time, more stress, the longer we have to spend out of our home environment meeting his care needs is really difficult. So yeah, it was just a really, really, really positive experience, and I can't imagine coming into hospital without having the support of a learning disability team to prepare you to come in. It just makes it so essential, and it just makes it's always hospital stays are always challenging and they're always difficult. And I do find that organised stays which are arranged in advance are often a lot smoother. I think there are things that could be done to improve the process for acute stays, because they can be challenging and things don't always get done in the time that you need them to be done. But the fact that you have an advocate in the learning disability team when things are stressful, when the ward staff are busy, when doctors are busy, nurses are busy, and you've just got that team of people, you have a contact, you can call them and they'll come and help you and they'll come and organise things and be your intermediate for you. It really, yeah, it's just brilliant. It really does make a really positive difference to our stays. So that's it for me. Hope that's been helpful.
Thank you, Sharon. That's an amazing story, and you didn't seem at all nervous. So well done. And just so good for you to share your experience with us, because it really does bring that to life, and it really helps us to understand some of the difficulties. But actually, when things go well, that actually the patient and the family benefit so much from that. So thank you so much. That's been great. And do stay with us for the rest of the event.
Okay.
So I'll come to thanking our speakers, etc. later. But we've now got a question and answer